Implementation science is a relatively new research field. I've been doing this since 1989, but there's probably, it's only, I think, in the last decade where there's been substantial international interest in the area. I would argue it's inherently interdisciplinary. No one discipline can make sense of this field because they have an insufficient grasp of the nuances that might influence behavior and policy and practice. And so I think if we want to advance implementation science, we need a wide range of disciplines to be engaged, including the clinical community, health services community, social sciences, design and engineering, informatics, methodologists. There are probably a range of other sectors that I've not included that you could just add in. I mean, basically, I think anyone who's interested in behavior change, in system change, in knowledge management has a role in terms of helping us advance this as a scientific field. The other thing I'd say is we need a broad range of forms of inquiry to advance the field. You'll get the sense as we go through this that I am someone who does systematic reviews, that I do trials, and I very much come from a sort of a quantitative experimental background. But actually, if we want to make sense of this field, we need also groups using mixed methods, qualitative methods, a broad range of inquiries. So again, there aren't any specific methods tied to this. We should choose the methods that help us answer the question that we have at any point in time in the field. This is my list of what might be covered under implementation science. And I'm going to talk about the bolded ones that we have here. But knowledge synthesis, we need to know what we should be providing. How do we know what is effective care that if we implement it in practice is going to provide the maximum benefit for patients and society? But we also need to do knowledge syntheses about what do we know about how we actually change practice and policy, how we do implementation. There's also research into the evolution of and critical discourse around research evidence. Research evidence is not self-standing. There's an awful lot of discussion about what it actually means, and also understanding at what point in time research is sufficiently trustworthy that we can implement it in practice, I think is a key area for the field. Research into knowledge retrieval, evaluation, and knowledge management infrastructure is really important. We have something like 670,000 randomized controlled trials published to this date, and that raises real issues that if you want to make use of this literature, how do you actually access that in a way that is efficient and allows you to identify very quickly the studies that you're interested in? Identification of implementation failures. If we want to start to do implementation in a healthcare system or implementation research, what are the priorities? Well, often they're going to be areas where we can demonstrate that there's a gap between what we know we should do and what we actually do. So studies that actually explore that gap are potentially very valuable for prioritizing how we move things forward. We then need to think about, well, if we've identified a potential target for an intervention, how do we do a diagnostic process that allows us to understand why at this point in time the program of care that we're interested in is not being implemented routinely in clinical practice? What are the barriers or facilitators to do that? And once we've done that, thinking about designing interventions that may address the targets that we identify, evaluate them, and think about sustainability and scalability of implementation programs. The field is littered with one-off studies that pop up and disappear, and we don't really get the benefit in the healthcare system. And finally, try to develop implementation science theory and research methods. So hopefully you get from that, I would see this as a very broad field, and others would probably put other things in there as well. It would also probably highlight the range of disciplines and the range of methodological perspectives we need if we want to address that. So moving on to knowledge synthesis. I started work in 1989 on my PhD, and at that point in time, there were really no global attempts to organize and synthesize the research evidence to make it easily accessible to any stakeholders in the world. We've come a huge way since then. So I'm involved in the Cochrane collaboration, and this is an international organization of now 30,000 people across 109 countries that have completed over 5,000 systematic reviews of the benefits and harms of different healthcare treatments and policies. This takes a lot of the heavy lifting that people can actually, rather than having to do the reviews themselves, hopefully go and find reviews that will help them sort of think about what they need to do. The evidence-based practice centers in the US are another sort of a responsive initiative to this kind of agenda. So we actually are in a position now where we're much better than we were 20 years ago. We also have both sort of a national and sort of a really high quality guideline programs around the world. And so we've done a huge amount already, particularly in terms of knowing or making the current research evidence base available to people. But the challenge is that just making the information available to them is not necessarily going to lead to the implementation of practice. It is a necessary but not sufficient step. But what I also wanted to say in this setting is that in the same way that I'd argue that if you wanted to know whether we should adopt a clinical intervention, you should be doing a systematic review and looking at the totality of the evidence. If we want to think about which implementation strategies we want to use, again, we should be trying to look at the totality of the global evidence and try and understand that and then interpret the applicability of the findings to our local settings. And so one of the things I'm involved with is the Cochrane Effective Practice and Organization of Care Group. We're the group in Cochrane that does reviews of interventions to improve healthcare systems and healthcare delivery, and these include professional, financial, organizational, and regulatory interventions. So we're currently working with about 600 people globally, and over a 15-year period, they've completed nearly 90 systematic reviews. And these are really difficult reviews to do. These are really challenging reviews to do. And we have another 46 that are ongoing. And I've just given you some of the titles of some of the reviews that we have in the professional and organizational interventions, and in the financial interventions and regulatory interventions. And so this is just highlighting that we can use systematic review methods to look at kind of quite complex healthcare system issues relevant to implementation. And they should hopefully help us make some sense of what's been tested elsewhere, what has worked, under what circumstances and context, which are most applicable to my setting. And this gives you an idea about how the field looks. There are now 140 randomized trials of audit and feedback. If you look across those 140 trials, you get a median absolute effect of about a 4% improvement in absolute terms, with an interquartile range of 0.5% to 16%. And one of the key issues here is we probably don't need many, if any, new trials of audit and feedback versus control. I think there are some settings where audit and feedback has not been tested, and it's worthwhile potentially testing them there. But if you're thinking about specialist care or primary care, we have a lot of evidence that this is something that, in general, is going to lead to a small but potentially important change in practice. The key issue from a research perspective is how do we optimize that? How do we use audit and feedback so we get closer to the 16% improvement rather than a 4% improvement? And we have to change the way we do science. We have to move from, if you like, the equivalent of a placebo-controlled trial to a comparative effectiveness head-to-head trial of different ways of providing audit and feedback. We'll require larger laboratories for us to do this in, because we're going to be chasing smaller effect sizes. But we really need to move that forward. There are 81 trials of educational meetings. In general, they work. There are only 3 randomized controlled trials of financial incentives in primary care published up to 2011, and there's only 1 of hand hygiene. So there are kind of areas where we have a lot of evidence, and we should probably be thinking about, we should be moving those into practice, and we should be thinking about how we optimize those areas. And there's other areas which are key, either policy levers or key challenges for healthcare systems where there's very little rigorous research that's been done that actually can inform what we should be doing in the future. We've also identified with the Canadian Agency for Drugs and Technologies in Health over 300 systematic reviews of professional behavior change interventions, and developed a searchable database where reviews are appraised and then summarized. So if you're interested in trying to make sense of this field, then here's the resource, and I provide the URL at the end of the slides that you might want to look at. And the other thing is, I've largely talked about sort of reviews that are focusing on experimental or quasi-experimental literature. There's a profusion of methods of thinking about how we can use synthesis methods to look at qualitative and quantitative evidence to really sort of be able to use this approach to look across a range of different types of inquiry. And here are just some of my favorite sort of resources in that area.